the Facebook Live.
Ah,
Test 1, 2.
test.
Test 1, 2. Okay. Got it. All right, we're recording. So 812.
This may be an awkward time to bring this up, but I think we ought to change the intro music.
Do you?
I don't think it's serious.
Should we bypass it today?
I think so. It doesn't convey the serious tone of the.
Okay. Then we'll just jump right in.
What's the name of his clinic? Foundation. Foundation Pain and Spine.
Yeah. Okay, he said he needs me to email him the link. Let me do that real quick. Okay. Participants invite. Okay, let's go over here.
Look at all those emails from Feed Finder. Busted.
Goodness. Okay. Justin at Foundation. Pain. Six. There we go. Hello.
Hey guys,
Doctor.
how you doing?
Good. How are you?
Cool. Great. Thank you for having me.
Yes, sir. All right. Let me go ahead and hit record on Audacity and we will get rolling.
Sounds great.
All right. Let's get your audio levels. Go ahead and speak for just a second.
Is this good enough? Can you hear me?
Perfect. All
All
right.
right.
Great. All right. Let's get going. Drew.
All right, well, everybody, welcome back. This is episode number 21 of the Recovery Lab podcast series. I'm Drew Hassan.
I'm Daniel Anderson.
And we are joined today. Thank you so much, Dr. Thompson. How are you, sir?
Thank you for having me. I appreciate you having me on the show.
Well, look, I appreciate your taking the time to do this.
Absolutely.
I feel like there's an imbalance here. I'm wearing a baseball cap and you've got a coat and tie on. But we'll just say that we're just being a little more relaxed in studio.
Yeah, absolutely. Absolutely.
I didn't know what the dress code was, so I just figured I'd wear a suit. It's not common for me either. So
No, you're good. You're good. We appreciate you.
Absolutely.
even coming.
Absolutely.
All right. You want to start with the announcements?
Well, all right. So the general introductory spiel for everybody listening is the same. Please comment. Please be involved. The more layers of interconnectivity that we can grow and develop, either via your comment or sharing the video, the better the recovery community is at large. If you've got constructive criticism, please comment with it. The general examples that I give are that you can get free Narcan at the Pines in Columbus, that's Columbus, Mississippi, or Mr. Moore's bike shop in Hattiesburg. There are a host of other places that also have it that you could find by searching End It for Good on Facebook. Angela Mallett and Christina Dent's place, their entity, their organization, they've laid out a pretty impressive network of Narcan distribution centers. And I think they're all free. I don't think you have to pay for any of it. Right. In that same vein, if you have any other information that might be beneficial for any member of the recovery community, please post it. I mean, the more everybody is involved, the better we will all be.
That's right.
Also, we need your financial support. We appreciate it. People have made donations, and we certainly appreciate that. We've got all this nice equipment that we need to pay for. We also have some hoodies, very attractive hoodies that you can buy. And if you go to Recovery Lab LLC, patreon.com. You can order the hoodies, see pictures of Daniel and me, because I know that's what everybody wants to look at. But more importantly, you can see pictures of people wearing the hoodies. We call it our mugshot page. It's pretty cool, really.
That's great. Also, let's not forget, we now have Patreon.
Patreon, yes, join, support us.
Yeah.
$5 a month, $1,000 a month, whichever one you want to pay.
Yeah, absolutely. Yeah, it's great. It's you know, if you do subscribe to that, you will have access to
Premier content
that you won't have access to if you're not a member of the Patreon. So I had no idea what Patreon was until we were at Christmas and my brother and brother-in-law were like, "Hey, why don't you have Patreon?" And I said, "I don't know what Patreon is."
Heard of it. I'd never really had.
Yeah, evidently the YouTubers, that's what they all do. And I had never heard of it. So that lets you know what I know about YouTube. But all right. Anything else that we needed to mention before we jump right in? All right,
Daniel drafted some bang up questions, so just get started.
Yeah, let's jump right in. All right, so I guess let's start with number 2, which is kind of a broad introduction into where you are and why you are where you are right now. So what made you want to go into the pain management side of medicine? What was it that really lit a fire underneath you that said, "Hey, I can do anything that I want, but I want to focus on pain and helping people deal with pain"? What got you started with that?
So, I mean, the short answer to that was just personal experience. You know, I think when you've gone through something, you can relate to it. Doesn't have to be the case with everything, but definitely was a factor for me. So I was active my whole life. You know, growing up, I played soccer, and, you know, in med school, to kind of manage stress, I'd play soccer on the weekends. So one day I was playing a game, I got hurt. You know, didn't think of it as anything big. Ended up being kind of a neck injury that stayed around for a long time. Went to my primary care doctor, went to physical therapy, still kind of just kept hurting and hurting. You know, was really frustrated because as a musculoskeletal type injury, it was kind of hard to find anything that helped. I wasn't big on taking medication, still am not really big on taking medication. So the therapy did help. You know, eventually it just took a while. You know, it was frustrating initially when I felt like it wasn't working right away to kind of want to give up on it. And so I wondered, you know, what can anybody do to help speed this process up, you know, because, you know, I didn't really have experience with that or enough knowledge at that point in time. And so fast forward a couple of years later, I got into physical medicine and rehabilitation, which is my primary specialty. And I found out that, you know, it kind of developed after World War II, treating people who had like brain injuries and traumatic brain injuries, and you know, also strokes and, you know, amputees and people of that nature, and musculoskeletal injuries kind of fell into that. So I naturally gravitated to that, you know, kind of being a very active guy. And then, you know, from there, pain management was a nice derivative. I originally wanted to be kind of a surgeon. And so I didn't love the lifestyle, you know, having to work all the time. So it was a nice work-life balance in pain, and then being able to kind of be more procedural and help people without, you know, necessarily getting on medications, which was my own personal philosophy of, you know, being able to help and getting injections to speed that healing process up. So that's where I got there.
Okay, great. So we want to talk a little bit about treatment and helping people to get into treatment and find the treatment they need. So what are the barriers that you have found throughout your line of work that has kept people from getting the treatment that they need? Specifically, I'm speaking more about opioids and things like that, but with just in general, is there anything that you're like, man, I wish this wasn't like this, so the people that need treatment would be able to gain access to the treatment?
Absolutely. You know, I think, you know, there's a big barrier, there's a big gap. You know, there's organizations out there that, you know, we've spoken about, like Recovery for America, you know, that talk about that gap and bridging the gap, that are, you know, really important. You know, unfortunately, you know, depending on what you read, up to 90% of the people out there who are candidates for treatment are not getting treatment. I think that is a difficult area to handle, because a lot of it is a lack of knowledge. You know, people don't understand the options that exist. You know, it's not something that's very public. Even in the realm of, you know, medicine, a lot of physicians are not aware of all the treatment options that exist and how to, you know, best serve their patients. I think also the general public doesn't know about it. And then finally, even when people do know about treatment, there's a lack of money, lack of resources for it. A lot of patients that we serve are not insured. Here in Texas, 1 in 4, 1 in 3, 1 in 4 people are uninsured. So that's a big factor. The other factor is that with that, even with insurance, the cost can be pretty great depending on the plan, the deductible, the copay,
Absolutely.
the cost of medication.
Just because you have insurance does not mean that you are going to have access to quality treatment.
Absolutely. And then also what kind of insurance you have. Certain insurance plans are not accepted widely by physicians. And that has to do with a lot of times the reimbursement there. But it makes it difficult for patients to find care sometimes, in quality care, and also to be treated, not like a number, but to be treated like an individual, which I think is really key in recovery process and being able to maintain that recovery process. So I think cost is a big factor, and then I think the last factor is judgment. There's a lot of judgment that comes into it with society, with families, with organizations. Sometimes people saying, this type of treatment is not acceptable, in maintaining sobriety or maintaining recovery. And so judgment, in society and even within the recovery community itself, I think impedes recovery for a lot of people.
You certainly sound like the unicorn doctor. I mean, with this awareness of the impact that pharmaceuticals have on people with addiction problems. I mean, I know that a lot of my addiction was spurred on by doctor manipulation.
Yeah, absolutely.
And it was, I mean, I don't know how much manipulation it was. I mean, they were more than happy to write the prescriptions for me. So has there been, I mean, you seem like a pretty young guy. Has there been a general pivoting away from utilizing pharmaceuticals as a first line of defense to pain mitigation?
Yeah. So, I mean, I'm a younger guy, I came out of training in 2015. So I've been out for 7-8 years now. And, I think that I benefited from coming behind some of the guys who didn't get that training, who didn't have that experience. I think as a field, we all try to do what's right for patients, and we're all a product of what we learn and what we, trained on. And I think that a lot of the time that you have people coming in who are told, opiates are not dangerous. There was a time in the 90s and the early 2000s.
Oh, yeah.
Where people said, there's no such thing as too many opiates. And so a lot of physicians who came out, who were older than me, came from that background of feeling like this is something that's okay. It's okay to have, opiates. It's okay to have, an unlimited amount. And,
They're not addictive.
They're not addictive. They're not, they're not causing any harm. And so, people took that and, and if you didn't continue to read up or, change your philosophy, because a lot of times things are different, and things change. That's the nature of science. And we learn over time that these things don't work. So for me coming in, I knew, that these things were not helpful long-term. Opiates were started out, we used them for cancer pain. So, it was used for people who were, sometimes had shorter periods of life or, had a disease process that was really tough. And, the idea that either they were going to transition, or that they were going to be healed and then we could wean the opiates was a legitimate one. But then it expanded out to, other patient populations, chronic pain being one of them. And, it was used very liberally in all areas of medicine and including dentistry. And so, with that liberal view on giving opiates out to everybody, including young kids, it set people up for this. And we know that roughly 10% of our country is affected by this. And that's what the statistics bear out, that, roughly 300 million people in the United States and about 30 million are, affected by this. And so that's a big deal.
Absolutely.
What is
No, go ahead. Go ahead.
how do the treatment plans laid out by Dr. Thompson differ from a more traditional opiate based, let's just numb it? I mean, how do you get people? I mean, I've looked at your website, and so I know that you have myriad treatment options, but what are the things y'all go to first?
Well, so from the pain management standpoint, I think there's 4 big categories of things that we can do for people. I'm a big believer in physical therapy. That's a big umbrella. So I would say things like, massage therapy, actual physical therapy, chiropractic therapy is a good place to start. Being more active is going to help with pain, but there are times when the pain is so severe that you can't do that.
Right.
I'm very big on interventions, I'm a find the cause type of guy. So, let's get imaging, let's figure out what's causing you to hurt. Let's work with, our injections. Pain has evolved a lot, even in the last 7, 8 years, where there's more interventions that allow us to fix the pain rather than just mask it.
Right.
And I think that's helped. And also working with my surgical colleagues, I have many surgical colleagues who are great, and they've even gotten more minimally invasive with what they can do, and that's been helpful. Then the last part of, medications is a tool, but I think, responsible escalation, not necessarily starting with an opiate, looking at other classes of medicines. I personally hate the idea of calling opiates pain medication. They're a type of pain medication, but there's other kinds of medicines out there
Right.
that can help. And then I think the last part of it is, um, more advanced interventions. And so those more advanced interventions are going to be things like, stimulators, pain pumps, things
Like a
that
TENS unit.
TENS unit, well, like a TENS unit that's implanted. These are
Okay.
things that are kind of like more durable, I feel like, in terms of maintaining treatment, putting the treatment in the hands of the doctor, so the patient is not tasked with trying to figure out how much pills they should take,
Right.
and helping to prevent issues like substance use disorder, because we're not just giving a patient a bottle of pills, 180, 240 pills and saying, well, good luck. I mean, I don't think that's necessarily responsible. So,
Right.
newer therapies are allowing us to take more control and being able to walk the patient through what they need to do to maintain, their pain level at a reasonable place and not have escalation of dose.
Brilliant. Brilliant. All right. So there's something that Drew and I know that I did for a fact, but what they call drug seeking. I'm sure you're familiar with it. Shopping for doctors to get whatever you want. And I imagine there is training for medical professionals to be able to not only identify these actions and these, things that people do, but also just deep down in your heart, you have to know. So when a patient approaches you and you have a feeling that they are drug seeking, how do you handle that situation? What do you do? And what do you do to mitigate the risk of enabling this person's addiction from growing?
Well, I think drug seeking, you have to be careful to label a patient as drug seeking. I want to make sure that I exclude every other possibility before we go to that point. I think that, as a pain doctor, I want to make sure that we're not missing something. So, we make sure we rule out all the organic causes first. And then afterwards, we kind of try to understand the factors, both physical and psychological, that are potentially causing that to happen. Is this financial stress? Is this emotional stress? What other factors are potentially causing the patient to turn to opiates as a coping mechanism? Similar to alcohol, sometimes people will turn to substances as a method of coping with, other types of pain that may not be purely physical. There's a numbing effect, a way to kind of check out. But once we find out a patient is, drug seeking, I think we talk to them about options. I mean, I'm big on setting out a menu for patients in terms of what we can do for them. And, in the recovery community, there's a lot of things out there that can be helpful. And there's not a one size that fits everybody. Everybody has to have a different kind of treatment plan. For some people that's, going to inpatient rehab. Some people it's outpatient. Some people it's medication assisted treatment. So I think it's looking at that patient and seeing what their individual needs are, family support, financial status, and then figuring out a plan that's going to work well for that particular individual.
Look, I think you hit on some stuff that I personally have found in my own life to be of value. It plays a part. I've noticed in my own behavior patterns how when I'm more stressed, when I'm fretting about something, my back hurts more. And I realize that this is like, it's almost like, this self-protection measure. I can divert my attention away from the thing that is the actual life stressor. And I can be, okay, well, I don't accomplish as much because my back hurts and everything like that. And I think that's really, I know it is common for people in recovery to deal with these, I don't know if I would call it psychosomatic pain, but it's something approaching that.
Yeah.
Mm-hmm.
How do you deal with people that, like, I think that's great. You're onto something about, I want to encourage exercise. I want to encourage physical therapy, because you all know that if you can get that dopamine released in a healthy way by the exercise, you're going to,
Be in a much better
your
situation.
worldview is going to be improved. Right. You're going to be less stressful, and thus maybe some of those injuries can be, or some of that pain can be mitigated.
Right.
I agree. I mean, I think the big thing is, getting people back to what they want to do. I think there's an aspect of pain that is emotional. We know this. The thalamus is kind of a relay center in the brain where we process pain. We think about, where it is, like you have pain in a certain area of your body. And then there's an emotional component that, because you have this pain, you have suffered this sense of loss, or there's a sense of distress, or a sense of, I can't do something that is very important to me. There's also, you talked about somatic pain. There can be somatization. We see it in children, where they have like a belly ache sometimes because they're unable to describe the pain they have, and there's nothing wrong, but there's something that's upsetting them. As we get older, sometimes we're able to evolve past that, but there's elements of that somatization that can happen even in older folks, depending on coping mechanisms that have evolved over time and levels of trauma that have occurred in the past. And so, I think the big thing for us is that we want to look at the patient and understand those factors, psychological, familial, and financial, that may be affecting pain in a way that's not just physical. A lot of times people are put on opiates because a patient comes in and says, well, my pain's a 10 out of 10. We all know that, someone else's 10 is not going to be your 10. And, unfortunately, we don't have an objective way to measure pain. There are some things that we can look at as surrogates for it, but there's no, pain, monitoring device that we can just say, this is what it's going to be. So for me, with a background in physical medicine and rehabilitation, I look at function. I tell people we don't have an organ that we work on function. That's our thing. We're not, heart doctors. We're not lung doctors. We're function doctors. That's what we do. And so, I ask the patient, what is it that you're not able to do because of your pain? That's what concerns me. So, if you're not able to play with your kids, you're not able to go to work, you're not able to garden, or whatever it is that, gives you joy, happiness, I want to find out that thing, and I want to get you back to that. And then whatever that level of pain is that you have, as long as it's a level that is, enabling to you to continue to function, then I'm okay with that. Everyone is going to have pain. Pain is a normal experience. Everyone experiences this, daily or every other, it's common. It's a normal part of life, but it needs to be managed where it's not interfering with the activities that you enjoy or need to do.
Makes sense. All right. Now, is there something that that you come across on a regular basis with your patients? Is there something that you wish, just a baseline that you wish all of your patients understood prior to coming in and sitting down at your office? Is there something that people as a whole miss when they come to speak to you, or not? And what is something that you wish that everyone would know and everyone be on the same page when they come into your office and seeking help?
So, I really appreciate that question, because I think it's about level setting or expectation setting for patients. I mean, a lot of times, when I've gotten patients coming in, they've had pain for a long time. And, we live in a society where things are immediate. And this carries over to recovery too, where people want to get, clean or sober quickly. And this can be done. Sobriety can be achieved quickly, but recovery is a lifelong process. And so
Right.
It's kind of the same thing with pain. It's a journey, so it's hard to come in and with any patient and say, we can fix this immediately. This leads to problems because sometimes people think, well, I can just take a pill and this can fix it. And maybe
Right.
it does for a moment. But the problem is that there's, you have to pay that debt at some point in the future. It can create future problems. And so, a lot of times that no is not to be, not empathetic to them, but it's to let them know, hey, I'm caring about not just the short term, but also the long term. There's a cost to putting you on this medicine. If I put you on hydrocodone or oxycodone, what is the long-term effects of this? What are we actually dealing with? Rather than saying we just need a quick fix, we need to think about what's life going to look like for you in 5 years, in 10 years. If you're 35 years old and I'm putting you on a hydrocodone 5 times a day, what does life look like for you at 55? What are we doing? There's got to be some plan that is looking at both the short and long term. So I think patients understanding that, we're not here to fix it necessarily quickly. We're here to fix it well. I think that's
Right.
and so we want to fix it well, and we want it to be a durable response, where the patient's getting that result and it's lasting, whether it be pain or whether it be maintaining that recovery process. That's what I'm focused on.
Right.
I like that. Not here to fix it fast. I'm here to fix it well.
Right. And oftentimes, as and I can speak for myself as being a drug addict and alcoholic in recovery, I am always, well, when I was using and oftentimes in sobriety, I want the easier, softer way. I want the quick fix. I want everything to be fixed now. So that was very nice of me to, or of you to say that, because that kind of reiterates the fact that, hey, just because there's an easy solution that will solve it quickly does not necessarily mean that it's going to be a solution that is going to last, and how important it is to, come with it, come at your pain with a reasonable expectation as to this is not something that we can always fix overnight, and that we do need to be open-minded when we discuss the different plans of action to be able to treat that pain. So that's pretty great. Okay. So we're talking about the problem, and I want to dive in just a little bit, if we could, into a little bit about Dr. Thompson, about what makes you tick. So, what is what gives you the most joy in life in general, and also surrounding your profession? So when you wake up in the morning, what are you grateful for? What are you thinking? What makes you tick, and what makes you be pleased to be on this earth?
I'm definitely grateful for God and for my family first and foremost. And, I think I'm just grateful for the opportunity to be a physician and have an opportunity to make a positive difference in our world. And so I know that sounds kind of cliche, but I think that for me,
beautiful.
Health is your wealth. People get focused on money, but if you don't have, spiritual, mental, physical health, it's hard to do anything else. And, money comes, money goes. But as long as you have health, especially in those areas, and you've got family and you've got God, anything is possible. Things can change, quickly. And, so I think that that's my focus. And so when I see my pain patients, I think about, these are people who've lost their health, whether it's emotional, physical, even spiritual health. We have to think about how can we get them better? How can we make them whole? Same thing in the recovery community. And once they have those things, once they have those tools, there's no deficit that can't be overcome, and come back on. And so I think we just have to focus on that. So the functional aspect for me is really huge, because, when, everyone's been sick, everybody can relate to that. And a lot of times people, are very judgmental of pain patients and patients who have substance use disorder, because they think just, well, let's just push through. And it's like, well, you've been sick too. You've had the flu, you've had something where you couldn't push through, you couldn't just willpower your through it. And then it's not something that people are choosing. Nobody chooses to be sick. It's just something that happens. And, these disease states are no different than, sometimes, cancer. It's bad, but like if you smoke for 60 years, that was a choice too. Right. So it's those people get sympathy, and I'm not here to lambast them, but I'm saying that the people who are alcoholics or drug addicts, they didn't choose this any more than someone who was smoking for 60 years chose to have lung cancer, So I think that we have to understand that, and we have to understand there's genetic factors, for example, hypertension. Everyone probably knows someone with hypertension, but, there are genetic factors that make that up, and there are, environmental factors. And so that 40 to 60% is genetic factors. And so that holds true for substance use disorder. So a lot of times people who have substance use disorder, maybe it's opiates, but they had a grandfather or a mother or a brother who had alcoholism. And so there's genetic factors that predispose them to that, having a first degree relative with that. And that's a lot of us, I have it in my own family. So, I think that looking at that with a degree of compassion, it changes things for people, in terms of how they view this and how they want to move. So for me, I'm grateful for the opportunity to be able to make that difference, to create a different narrative for people. We had 100,000 deaths in the US last year from opiates. And so it's like, that's our future. Most of those people, are younger than me, and I'm not that old of a guy. So, that to me, I feel like I'm, making a difference. I feel like that's making our world a better place. We're helping not just the individual, but we're helping the whole family around them. So, that's, 3, 4, 5 or more lives that we're touching with each person we help. So that's huge. And what's the impact going to be on the future? Well, God only knows. So that is what makes me get out of bed every day, to help people get back to their lives and, make a difference that they've been, destined to make.
Absolutely. Beautiful.
You mentioned when you treat your pain patients, what other kinds of patients do you treat?
So I have substance use disorder patients that I treat, and I treat pain patients. They're, similar populations and different populations. That's kind of an area that's been interesting for me to kind of see and learn about. It's like a coin that has two sides. If you think about pain, there are pain patients who come and have legitimate pain, and sometimes they'll be put on opiates legitimately. But will, for reasons I mentioned before, with the genetic factors, will sometimes be that 10% who end up getting hooked on pain medication. And if you go back and look at things like even like Dr. Drew back in the day, a lot of people would come in and get hooked on pain pills, and you'd see these reality TV shows where people are trying to, get off opiates, and they were prescribed it because they broke a bone, or, they had something happen and it was legitimately prescribed, and, there's unlimited refills. And then next thing you knew, they didn't know how to get off, and this is a story that everybody has heard from a friend or family member or somebody they know. And then, it became a willpower thing where it said, we'll just lock yourself up for 3 or 4 days and go through withdrawal, and then you'll be fine. But the reality is there's an 80 to 90% failure rate there. So we know this is not just a willpower issue. This is a chemical issue in the brain. There's neurotransmitters that are involved in that. And so, understanding that, we know that we need to treat this as a medical condition. There's medications out there that can assist and help with that recovery process. And then in addition to counseling and other, group and individual therapies and rehabs that exist out there. So I think it's not it's this or that. It's a comprehensive treatment algorithm that you've got to think of for your patients. And pain's the same way. Like I mentioned before, it's not just medicines, it's doing injections, it's getting imaging, it's looking at therapy, it's bringing everything to bear. You're not serving the patient well by just saying, here's hydrocodone and get out of my office. That's lazy medicine, and it's easy. A lot of patients are treated that way because physicians think, well, if I keep giving medicine, they'll come back every month. That's revenue. And it's not an argument, because sometimes it can be difficult having those tough conversations. But at the end of the day, it's worth having those conflicts, having those conversations to get to the other side of that, where you're going to have a better, more satisfied, happy patient with a better long-term outcome.
Absolutely. Absolutely. What you mentioned other medications, and I imagine that Suboxone is on that list. What are your thoughts on Suboxone? Is it helpful in your practice? Do you like it? Do you not like it? Tell us a little bit about that.
So I like Suboxone a lot. I know there's a lot of debate in the recovery community about medication-assisted treatment and the role of Suboxone. And the most common thing I hear is, I'm just giving up one substance for another substance.
Right.
And, I understand where people are coming from with that, but I think that you have to look at it like this. And this is what I tell people. We have our office is up on a higher floor of a building. And I said, we kind of are on this floor, that's a fact, me and the patient, and your car is downstairs. And so we have two ways to get down there. One is to jump out the window. The other is to take the elevator, the stairs down. One is clearly faster than the other. If we jumped out the window, we'd get to the parking lot a lot faster, but it would be catastrophic. If we walk down these stairs, it's going to take longer. And if we never go down, we're still safe. And so, thinking about it, like from where we're at, once you've taken opiates for a long time, your body is wired for that.
Right.
And Suboxone, what it does is it hits the same receptors that opiates do. However, you don't have the dose escalation. And ultimately, the biggest thing is life and death, which is that with Suboxone, you're safe. If you stay on heroin or stay on pain pills, the dose is going to continue to escalate and the risk of dying remains there. With Suboxone, the risk is markedly reduced, if not there at all, depending on the dose that you're taking. And, at that point, you're not seeing the dose escalation happen, and you're seeing a patient who's healthy and happy and able to be a functioning citizen, and I make that very similar to someone who's on insulin. If you're a diabetic, you can lose weight, you can eat differently, you can do it the natural way. But the reality is most people are not able to. And so you stay on your insulin and you don't have diabetic coma. So, I see Suboxone in the same light as that. If a patient's on it and they're doing well, it can be maintained. People can do well, and they can, and to that patient is sober, and they're in recovery. If they want to taper down, absolutely, let's go for it. But if your body's saying, I can't do this, and you're living a good life on Suboxone, then I look at you with the same respect as somebody who is, tapered off completely. It's not a one size fits all treatment. So,
Sure.
Yeah.
Okay. Yeah, I personally think that it certainly has its place.
I've pivoted on this. I used to be against it completely. I thought it was, modern day and abuse. Like, why, this is not good. And then I had a counselor, a therapist that I respect, was on the podcast early on, and he kind of laid out this argument, like, look, I can get somebody on Suboxone whose life can stop falling down around at their feet. They can become a functioning member of society. They can do those things that grow and enhance a natural self-esteem. They can become a better person, and they're not going to have that chance at all.
Right.
If they're using, and not for nothing, this may keep them from ODing and dying.
Right. Exactly.
So,
especially with the prevalence of fentanyl and everything. now.
everything.
And that
So-
just happens to, I mean, so I've had a patient, who has passed away, and what happened, really was that there was a big push to get that patient off Suboxone, from the family, from, referral sources, from even the hospitals, and so it's like, okay, we can taper people down. That's not difficult to do. But the question is, are they going to maintain that sobriety? So, patient discharges, the patient goes to, a program, and, the patient's told they have to be off Suboxone in order to be in a program of that sort. And so, the patient is, there for a little bit, and then the patient, quits the program because they want to be on Suboxone because they're not feeling good. And we know why, physically, and so at that point, they go back and look for something that's going to satiate that craving. And that sometimes isn't Suboxone. Unfortunately, it's fentanyl, it's heroin, it's, pain pill. And, the problem is when you've kind of been off, or you go back to using what you've been using, you can overdose very easily. And so,
Sure.
In this case, this patient, ultimately expired as a young patient, and so, these are the things that, where people were hardline about, that I'm confident that if that patient was on Suboxone still, they probably would still be here today, but that's one of those decisions that's, pushed through, and it's not necessarily a physician level decision always. It's a, patient, family, and institutional level decision, so I think that we have to get past this, you have to get off mentality to be sober. I mean, if you can, absolutely. We will try to take every patient off Suboxone if we can. But at the same time, you wouldn't have someone who's diabetic or who has high blood pressure, and you try to take them off their insulin or their blood pressure pill, and their blood pressure spikes or their blood sugar rises, and you say, well, just stay off of it. That would be irresponsible medicine.
Right.
So I don't understand why, I think we have taken moralism and tried to say, well, this is a willpower or a good and evil thing. And that's not really what this is about. We all have, illnesses and things. And because we haven't understood the, neurobiology of what causes this, we have made it into a good and evil or moralistic thing. And it's definitely not that. And so I think that that's where we have to give each other grace and say, your way of going through this is your way of going through this. You're sober. But if you're able to take care of your family, work your job, take care of your kids, then you deserve as much respect as the next person.
Absolutely.
Look, I want to hit you with a controversial topic, put you on the spot.
Okay.
One of the main opiates that I abused, the opiate that I abused the most, was Dilaudid.
Mhm.
And Dilaudid people are Dilaudid people. And I 0 times saw somebody overdose on Dilaudid. When it became more difficult to get Dilaudid, people did more heroin, and those people die all the time. Where are you on decriminalizing drugs? And where would you stand on that?
So decriminalization of drugs, I think I'm for it. I think the big thing is that we need to, help patients rather than, put them in jail. Even sometimes I feel like, I've worked with the criminal justice system. I know some of the judges here in town. It's difficult to send someone to jail and just say this is going to fix the problem. We have to get to the root of the issue, which is that there's a neurobiological issue and this patient needs the adequate treatment, and a lot of the behaviors that are driven from that addiction, stealing, things like that are coming from this. And so if we fix that problem, we're going to have the issue go away. So a lot of times I've had patients who even have gone to jail, and then when they got back out, they started using again, or they're using in jail because they're able to get the substance still, through whatever means that they may use. So I think decriminalization of it is a big thing. More people in jail in America than there are anywhere in the world, including China, who has 4 times the population that we do. We have to think about, using our resources better to help these people and help them get back to being functioning members of our society.
Nancy Reagan just said, just say no.
Yeah.
I don't think that worked out.
Yeah.
I don't think so. I mean, I appreciate, there's primary prevention, trying to keep people off of it. So obviously, I'm not advocating that people should use drugs, but, after that, you have to think about different levels, secondary and tertiary levels of prevention that are out there to help, at-risk populations and to help people who are already using to reduce their harm. And so I think when you look at it like that and say, okay, well, some people aren't going to be primary prevention. Some people are tertiary, where we're thinking about, needle exchange programs, and we're thinking about, harm reduction strategies here. Criminalizing this is just creating that cycle of problems. If we can get people, back to work and not having felonies and misdemeanors on their records and being able to continue to support their families, we're not putting these people still have families that have to be supported, and we're putting that back on the state, and back on other people. So, if we can get that person to be self-sufficient again, I think that that's going to be better for all of us.
Absolutely. And beautiful. I want to circle back. There's something is just screaming in my head. I want to circle back to that initial question about insurance and how the insurance is not always going to pay. So what we've learned through the podcast is through Brad Garraway with Clear Path Interventions is we need data. We need data to take to the insurance companies and say, look, it is cheaper for you to pay for treatment now than it is to deal with the consequences that are going to happen as a result of this person not getting the help that they need. What are some of the data points? What are some of the things that you think that we could do as a corporation, as a organization to hurry up that process, and B, fight the insurance companies? So is there something that comes to mind with you when I talk about that would be, okay, this is a beautiful data point to give. This is a beautiful data point to give to an insurance company to say, look, here it is in black and white. If you bite the bullet and pay for long-term treatment now, the possibility of it being less expensive in the future is very great.
I think the data is definitely out there. And I think that, back to my point of there being different routes for different patients, not everybody needs an inpatient treatment program. A lot of people I think can benefit from even doing outpatient, and then coupling that with an intensive outpatient program, or, staying on MAT. And that's all going to be cheaper than, going the route of, hospital, admissions, or, being in the ICU after an overdose. So, I mean, for us, we focused on both ends of the pond. I've done inpatient and I've done outpatient. Outpatient's a lot cheaper. The cost of outpatient treatment, I think we calculated for our clinic, would be almost 12 years of outpatient treatment for like 1 month of inpatient. So, I mean, it's
Right.
Wow. That's crazy.
It's a pretty big difference. So, you're looking at, massive differences. And, so certain people who have good family support, who are adequately motivated, and have the financial wherewithal, outpatient may work for them, if it's not, dual diagnosis or there's not multi-substances, that can work. Sometimes people who have less family support, less, desire in the moment, inpatient is great because it's a good launching pad, into something more, in a recovery. And, still it's going to reduce costs. So I think it's making public officials and making the public aware of what options exist. Also, there's one of my favorite websites is called streetrx.com. And what I like about that is it shows the cost of what drugs cost on the street, because, people will sometimes say, oh, I can't afford recovery. But, for outpatient treatment in particular, the cost of the drugs themselves is going to be more than what it would cost to start pursuing treatment. So, for a milligram is usually $1 on the street. So, the dollar per milligram rule is the one that I kind of use. There are some exceptions there, but, a 10 milligram pill of hydrocodone is usually going to be about $10, $5 to $10, depending on, 50 cents to $1. $1 makes the math easy. So that's generally what we see. And so, if you're buying 6-7 pills a day, the math becomes $60, $70 a day, times every day. So you have a mortgage payment pretty fast,
Right.
which is, a lot cheaper than even outpatient. So, I think being aware of that, what's the cost of this, or if you're stealing stuff and you get hit with a misdemeanor or a felony, the legal cost of that, the cost of not being able to go back into the workforce after this follows you. So these are things that, people need to think about that are costs that are not considered. So, definitely I've had patients, one lady I treated told me she'd saved $25,000 over a span of about 6 months.
I believe
So
it.
pretty cool to see, so I think just looking at it like that can be helpful, and we're happy we do that with our patients a lot, just kind of showing them how they're going to actually get ahead.
Pretty great. Pretty great.
Well, I did hear you mention about imaging, and y'all need to get the price of those MRIs down.
Yeah. How are we going to do that?
That's
Absolutely.
astronomical.
So I'm big thing is I think transparency in medicine, transparency in cost. There's an article I read. I wish I could remember the name of who wrote it, but basically talked about kind of the dumb bird phenomenon of medicine. And so the idea is that like birds fly everywhere and they land wherever they land. And so, if you think about gas stations, certain gas stations, it may be $4 a gallon and people fill up there. And there are certain gas stations that are $2.50 and people fill up there. And, it's a convenience. And sometimes that's a factor. And also even worse than the gas station world, there's a lack of knowledge in terms of cost, and so an MRI may cost $800 here. It may be $350 here. And so, the customer needs to be able to have more transparency in the pricing that exists there and more options to say, well, maybe better for me to pay cash than to pay, my deductible, which may be a greater amount, and so I think asking the right questions and then creating greater transparency in pricing in medicine is key. I think especially as we see premiums and deductibles rise, I think there'll be more of a market for, cash pay, and there are businesses out there that are doing that and meeting that need.
I completely agree. The
Yeah.
transparency is huge, and knowing what options and what resources are available to you is super important.
Mhm. Well, to kind of like clarify that the dumb bird comment is that the hospitals are waiting and hoping that some birds will land in their lot. And so when those birds land there, they're able to take advantage of them. And so, the customer being the bird is unable to be notified or know that this is an expensive lawn. You're landing in an expensive yard. It's going to cost you more money than landing in a yard where, it's more reasonable. The birds don't know that. If they're having to pay to land in that lawn.
Yeah, they don't even know they have the option to shop it, so to
Right,
speak.
right.
Right. So that's what we mean by that. And so, that's how healthcare has existed, especially in certain markets, especially here in Dallas, Fort Worth, you see that a lot. And so there are options, getting imaging done at a hospital is going to be more costly than doing it at an outpatient center, so, sometimes patients want to go to the big hospitals, and I try to discourage that because I say, it's going to be more difficult a lot of times for us to even get the imaging back. And also it's going to cost more probably for you, depending on the plan. So it's just things that people can be aware of and know.
Yeah, I gotta say, what would you? All right, so let me just tell you a personal situation, and Peter has, I believe, sent my mom a referral to come and talk to you. But my mom deals with serious pain in her back, and she is anti opiate medications. Period. So what do you tell to what do you tell a patient? What kind of hope do you give a patient that says, I am living in pain every day, but I do not want to take opiate medications? Do I have options? What do you tell them?
Absolutely. I mean, I love patients like that. I mean, I'm absolutely, willing to bring out the full, armamentarium that we have in pain. I think that it's a really exciting time for me professionally, because there's so many options that have been coming out. There's neurostimulation, there's regenerative medicine, there's, all sorts of procedures. I went to a conference not too long ago, and I was at a lab where we were looking at different procedures they were teaching physicians how to do. And I was like, wow, there's almost 50% of the things in the room here I didn't even learn in fellowship. They're just like new things that are coming out. So, patients sometimes come in and say, I've tried an injection, and I kind of laugh and say, well, I've got 45, templates of injections that I can do. So, one injection is exactly that. It's one injection. It's no different than trying one pill and saying, well, medicine didn't work for me. And it's like, well, that's just one pill. So, there's a lot of good things that we can offer her and any other patient like that. Regenerative medicine is a really cool thing. You can take cells, and help regenerate cells that have been lost. There's neurostimulation where we're changing the electrical patterns that cause pain in the body. There's even some devices where we're going and fixing the mechanical problems that are in the body. And then if we can't do it on the pain side, guys like, Dr. Derman are able to do that, well, and do it in a minimally invasive way. So, I think we have a great approach. I think guys like him and guys like me, we focus on getting to the source, figuring out what's wrong with the patient. And then when we can fix that issue, typically the need for opiates disappears, so.
And that's beautiful. That's beautiful.
That is beautiful.
A life without a reliance on opiate medications is just, Dr. Derman was posting about that the other day, that he performed surgery on this young lady who, her daughter was in cheer, and she was completely unable to do anything. And Peter went in with minimally invasive surgery, and she was able to get off those opiate medications. And she sent Dr. Derman a letter saying, you basically restored my life. And it's beautiful to me that doctors are not just all like completely enmeshed with opiate medications now. And that's, I know very little about the medical side of things, but it certainly seemed as though for a time, the go-to solution was opiate medications. And being in recovery and seeing the downside of that and the opposite.
Well, if you
side of
believe
that.
everything we've heard about Purdue, I mean, they legit told people,
Yeah,
it's not addictive.
yeah,
If they act like they are addicted, that means you're not prescribing enough. I
Right.
mean, if you're a drug addict, this is as good as it gets, man.
right.
Mhm.
That begs the question: have you seen what's the movie with what was it, Michael Keaton?
Dope sick.
Dope Sick. Have you seen Dope Sick?
I haven't seen Dope Sick, but I have seen Crime of the Century on HBO, which talks a lot about what you're talking about with Purdue. It's a documentary, and they really talk about, there's a guy on there. I remember, I think he said he was taking 22 oxycodone twice a day, so you have to literally chew them up. And, there was physicians who were getting rich off this. And then, the government's done very little to stop this. I think there was one of the senators out of in Connecticut, I forget his name. I think it might've been Senator Dodd, was, basically saying that, this is my constituent. Purdue is in my, backyard. We've got to protect Purdue. And so, the Congress, voted, the Senate, I should say, voted 100-0, to protect Purdue. This
Right.
was obviously as bipartisan as it gets. And then it went to the president, and, I think it was President Obama at the time, he signed off on it. And so it's like, there was no resistance. Administration changes, President Trump comes in, same story. So, this is something, if we look at the number of opiate deaths going back to the first President Bush, it's gone up regardless of administration, and so it's something that our government has failed us on, on both sides of the aisle, in terms of getting this fixed.
Yeah, and Senator Dodd was then on payroll for Purdue Pharma and was making 8 times what he was making with the government.
If it's true, like the little card that you get when you're in the hospital, like how bad is my pain, and it goes from smiley face to frowny face.
Right.
Apparently that was Purdue made those.
Yeah.
The graphs they submitted to the FDA were skewed in such a way as to
completely misleading.
They were completely misleading, that they were made by these statisticians, and they were like, look, this was a knowing falsehood.
Right.
The way that y'all manipulated these graphs to show, I guess, pain mitigation versus dosage.
Mm-hmm.
Look, I know we're close to running out of time. Got one question for you. You mentioned about people that get hooked on opiates as a result of a treatment for something like some kind of compound fracture
or car wreck.
Is there an observable difference from a physician's position between the man or woman who develops a dependency later in life because of a injury or illness that was no fault of their own, and then the man or woman who has had chronic substance abuse problems, from their, say, teenage years forward?
There's definitely a difference. I think people who are introduced to opiates later in life are less likely, it seems, to develop those, substance use disorder problems. So, if you're using them younger and recreationally, that can be a problem because you're rewiring, the neurotransmitters earlier in life. I'm a big believer, and this is kind of more anecdotal than scientific, in kind of a pain bucket. And so, opiates, I'm not opposed to writing opiates. I do write them, but I think it's about writing them appropriately and for the appropriate period of time. And so, if someone breaks a limb, obviously I think that opiates are a appropriate medication to give the patient, but it needs to be for a fixed period of time, a fixed amount, and under close supervision. So some good work has been done with this in terms of, pharmacies working with shorter prescriptions, more frequent visits, to kind of reassess. Some of this is, the way the system works, where, people want these 30-day scripts, and it's like just so they don't have to come back in so frequently. But in some cases, it is good to be seen more frequently so we can have a better, handle on this, and, work to taper more aggressively, more quickly, So, even for substance use disorder patients, sometimes the most common question I get is, well, now that I'm off hydrocodone or oxycodone, I'm going to have gallbladder surgery or some surgery. And, can I have pain pills again, or opiates, I should say? And I say the answer is yes. We can give you oxycodone again, or we can put you on this, but it needs to be under close supervision. I want to know what we are giving. Sometimes I'll be the one to prescribe it, and then we're going to get you back on Suboxone, or we're going to get you tapered back off of this, and we're going to do this under the supervision of you, and then even ideally a family member or friend who's giving you the pills, so that we make sure that this doesn't get back out of control. So it's very well, coordinated, and we're working on that. So I think you can see a difference in those populations.
It's interesting to me how the behavior and the physical kind of merge together at some point. I mean, I better not tell that story. That one might get me in trouble. But people can have, if I'm in the hospital bed and I've broken my femur, I don't want to hear about, where are you emotionally right now?
Right.
I want to hear about that morphine pump.
Right.
Yeah.
And how, if you have a legitimate need for a narcotic and you're in recovery, it oftentimes is not the end of the world, provided you have the right frame of mind beforehand.
Right.
Yeah.
It's interesting.
Yeah. You gotta be, well, dare I say, spiritually fit, and you can do and go
Right.
anywhere. So, well, we don't want to take up any more of your time. We are
Dr. Thompson, thank you so much.
unbelievably
Thank you.
grateful for you joining us and taking the time to share with us. And we wish nothing but the best for you.
Likewise. And thank you. I appreciate what you guys are doing and spreading awareness. And this is great work. This is God's work. So really appreciate you guys doing this.
Thank
Yes,
you.
sir. Thank you, sir.
Thank you.
Bye-bye.
Bye.